Welcome to the Impact Education's PayerTalkCE program. Today's program is a case challenge about age-related macular degeneration. I'm your host today, Dr. Gary Owens, both a former primary care physician as well as a payer medical director. This PayerTalkCE program is jointly provided by Medical Education Resources and Impact Education, LLC, and is designed for a half hour of continuing education credit. This activity is supported by a generous educational grant from Regeneron Pharmaceuticals, and we want to thank them for their support. At the end of today's program, you'll be able to complete an evaluation, which must be submitted to receive credit. Click Complete Evaluation in the navigation within the activity. Once you complete your evaluation, you need to click Claim Credit to download your certificate. For pharmacists, submit your credit to CPE Monitor. It's my pleasure today to be joined by Dr. Jordan Graff. Welcome, Dr. Graff, and would you mind introducing yourself?
Thank you, Dr. Owens. Yes, I'm Dr. Graff. I'm a retinal surgeon and ophthalmologist. I treat macular degeneration, diabetic edema, and other retinal conditions in Phoenix, Arizona. I'm also a clinical research scientist involved in about a dozen clinical research trials for new and progressive treatments for these macular diseases.
Well, thank you very much, Dr. Graff, for that kind introduction and your wealth of experience in this area. Today, we're going to be talking about AMD. It's one of the conditions that's a focused area for payers. It's not a high prevalence condition, but it is the number one cause of blindness among Americans over 65 years of age. So it becomes a particular issue for payers that have Medicare Advantage plans. It does come with a substantial cost of treatment, but at the same time, these treatments have really revolutionized the management of AMD. But I think because we often have different backgrounds listening to this case, it's always good to walk through a little bit about the background of the disease, mostly in terms of progression, presentation, and just a high-level overview of treatments. So with that, I'll turn the floor over to you, Dr. Graff.
Oh, thank you, Dr. Owens. Yeah, macular degeneration, as you noted, it's the number one cause of going blind in the United States of America for our patients over age 65. It's one of our greatest battles, is trying to preserve and restore as much vision as possible in patients with macular degeneration. Macular degeneration was neither kindly nor incorrectly named. Unfortunately, it does exactly what the darn disease says it will do. It degenerates insidiously the macula. Macula is just a fancy Latin word for the center of the retina in the back of the eye. That's what we get all our center vision with, that central few degrees that you read with and drive with and watch movies with and recognize grandchildren's faces with. That's the macula. And so macular degeneration could be seen as the retinal equivalent of other degenerative diseases. For example, cartilaginous degeneration, we use the Greek name arthritis. Or cerebral degeneration, we use the eponym Alzheimer's. And like arthritis and Alzheimer's, retinal degeneration of the macula, this aging process, is progressive with a combination of genetics and birthdays. And just like if you have the genes for Alzheimer's, it doesn't trigger when you're 12. It takes time and the genes. And if you don't have genetic triggers for it, the likelihood of that is much, much less. There are two types, two flavors, if you will, of macular degeneration, dry and wet. Dry is the slow drying degenerative changes, just like maybe the skin changes with age and sun exposure and other factors. And wet degeneration is on top of the dry, where you can have leaking or bleeding, abnormal blood vessels grow. That requires more aggressive treatment to stop devastating blindness. And 25 years ago, we had different types of laser, but that's it. In the last couple of decades, 17, 18 years now, we have anti-VEGF therapy and variations on that theme for the last decade and a half to drastically change the treatment and preserve as much vision as possible in wet macular degeneration. That kind of gives a bit of an overview of the pathophysiology, I think, and how it presents our patients when they show up to us, how we're trying to treat this disease process.
And that is an excellent overview, and really will lead us into, we're going to try to personalize today with a bit of a case example and get your comments on this case example. In this case, it's a 75-year-old male. He lives in a rural community. Really, there's no support. Their children are grown and live out of state. And recently, he began to complain of decreased vision in his right eye. was about 4 weeks of decreased vision. And he also noticed a black spot close to the center of his vision. The spot came with both near and far vision. It doesn't move. He's had no history of eye trauma, never noticed any eye pain, redness, discharge, and his only comorbidities are hypertension and hyperlipidemia. He initially presented to his primary care provider, who in turn referred him to an ophthalmologist. So I'll ask you, Dr. Graff, how typical is this case that I just presented to you? And what are some of the things you're looking for to differentiate between, as you already noted, the two varieties, dry and wet AMD?
Well, I'm glad you present this case. It's a really good one for us to wrap our minds around, kind of a classic example. An older patient who has a sudden onset of this smudge or a black spot distortion. We call it scotoma or metamorphopsia, just like a metamorphosis, this distortion of the vision. And the problem is that patients can't always tell if this is wet or dry. Quite frankly, a patient may have mild dry degeneration for years, and unless they've been getting regular eye exams, they may not know it until they start to see distortion, smudges, a spot in the vision. That's a classic presentation. The patient thinks that it's sudden, and they'll say, well, I was fine until this. That's kind of like a heart attack. Well, a heart attack didn't happen because you ate 5 French fries yesterday. It built up over many years, and then the acute occlusion caused the problem. Likewise, dry macular degeneration by genetics, the aging effects of unprotected sunlight, smoking, and other factors progresses, and the patient may have mild or even no symptoms until one of these little abnormal blood vessels grows, and when it bleeds, bam, there's a spot. It's a few hundred microns in size, less than a millimeter perhaps, but the patient notices a big smudge. So that's a really good presentation. Usually that distinct smudge or distortion is an indicator of wet degeneration. At least we tell our patients that's what they watch for. We can't always distinguish on symptomatology between wet and dry, but that is a good indication. And just like a patient with heart disease would present with chest pain or shortness of breath, we want them to assume until proven otherwise that it's a heart attack. Likewise, if a patient has a sudden onset of distortion or a smudge or a defect or a blurred out spot that shows up suddenly in their vision, we want them to assume it's wet, call and get in and be evaluated, usually within that next week or so.
Okay, well, thank you for sharing that, and especially that somewhat relentless progression of disease. We often tend to think of this as an acute type of condition, but there's stuff going on in the background. And at this point, from a payer's perspective, we generally aren't aware of these patients because they're in the process of an evaluation, which leads me right into examination and diagnosis. And using the Amsler grid, we can see that the left eye is normal, but the right eye has that blurry spot near the center of the grid with wavy lines. The visual acuity in the left eye is 20/30, but in the right eye, it's 20/80. The dilated fundus exam shows a left eye with clear view, a CDR of 0.5 with sharp optic disc margins. There's a flat macula and scattered large soft drusen within the arcades. The vessels are otherwise normal, as is the peripheral retina. However, the right eye also shows a clear view. The CDR is 0.6 with also sharp optic disc margins and a flat macula. Again, scattered soft drusen in the arcades, but there's a 1 disc area of subretinal hemorrhage in the macular area near the fovea. So this really fits very nicely with the description you just gave. What are some of the things you're now looking for in the exam, and what markers or other indicators of disease activity might predict where this patient goes in the course of therapy?
Well, this is a great example, a really good classic example where you see the drusen and the pigment changes. Everything else seems to be normal. Vision's good. You notice the patient's vision's quite darn good for being in their 70s in the eye that has dry degeneration. They have no symptoms and their Amsler grid is normal. Those symptoms the patient sees in the grid correlate with the drop in vision and correlate with the exam you see here of that hemorrhage. That spot looks pretty impressive on the fundus photography zoomed in like that, but a disc area, frankly, is about 1 millimeter. 800 to 1,000 microns or so. And so that's where we go next on my examination. I'm going to get an optical coherence tomogram, an OCT, probably a baseline fluorescein angiogram, and look and confirm what I'm clinically suspecting, that the source of this bleeding is not some other masquerade, but indeed wet macular degeneration. And that moves me towards prompt treatment. I usually, and this is important for our payers to understand, it's possible the patients had symptoms for a while. It's possible it took them a while to get in here. It's possible the granddaughter took off work to take the patient in, and they're here with blood and fluid in the eye. And I know that blood sitting on neurologic tissue for a long time will cause more permanent damage. So I want to try and treat right away. We oftentimes reach out to our payers and communicate with them in hopes that we can use at least first-line therapy right away, same day of diagnosis. And that guides me in getting treatment right away if I can.
No, and you do bring up a very good point that, like many other diseases, patients are often symptomatic for a while before they, number one, decide that they need treatment. And then number two, sometimes that initial presentation, like this patient, to a primary care physician then leads to a referral, which may take some time. So what is the impact of delaying treatment in AMD? Why is that imperative there?
It's significant. The blood has the hemoglobin has a heme unit and iron in there, and that blood and fluid on neurologic tissues causes irreparable damage the longer it's left there. So the quicker we can get in and start treating, now it's not pull the fire alarm emergent, but it is prompt and urgent, and the outcomes are better the earlier we treat these patients. We want to get rid of the blood and fluid, restore, and we know per the trials, the initial trials that were done, Anchor and Marina, showed us that we can get 97% of patients, we can stop the devastating multiple lines of vision loss with aggressive treatment right out the gate, and we can regain vision. Sometimes multiple lines of vision can be regained in 30 to 40% of patients. We also know, based on the findings of the drcr.net protocol T treatment, that there's a favor towards using branded medication versus what is oftentimes seen as first line, which is the bevacizumab molecule or Avastin off label. And so those disease severity, more blood, more fluid, center involvement, move me towards wanting to treat sooner and move me towards wanting to treat with on-brand FDA-approved medicines.
And certainly it brings up a bit of a payer dilemma, because on one hand, payers have a fiscal responsibility to their clients, in this case, Medicare, which is a little bit different, but in those younger patients to the commercial employees, versus trying to make sure that this gets treated quickly and in a way that's going to ultimately lead to the best visual outcome. So it's certainly something that payers need to think about and really look carefully at their processes. So with that, let's look at the treatment phase of this case and see how this patient was managed. As you already pointed out, classic case, he has wet AMD in his right eye, and he was recommended to begin with intravitreal VEGF immediately to preserve vision. As is fairly common among payers, bevacizumab is the only anti-VEGF not requiring a PA, and if you look at a lot of payer policies, that certainly is the case. In this case, the treating ophthalmologist opted for an FDA-approved agent for efficient vision preservation and the ability to treat and extend out the 12 weeks beyond and between doses. It took the patient nearly a month to get to his PCP, as we already pointed out, then longer, factoring in the referral to the ophthalmologist. He also lives in a rural location, as you pointed out, so a family member or someone may have had to take time to get him for a visit. And so in this case, intravitreal aflibercept was prescribed because the Medicare Advantage plan required an additional step through ranibizumab biosimilar as the preferred ranibizumab agent. So what other medical policies are you seeing in this space regarding anti-VEGF therapy, and how has step therapy requirements affected your clinical practice? And in particular, we're always interested in how they might affect outcomes for patients.
I'm really glad that we're going through this. This is the conundrum I know that our payers face, and that we have the same goal. We want to save as much vision as we can in the patient. We want to reduce burden. We want to reduce risk. And the step therapy, this description is also fairly classic from a payer authorization perspective. It's not uncommon to treat with first-line bevacizumab and then try and move to an on-label FDA-approved medication that carries with it potentially less risk because we're not using an off-label mixed up in under a sterile hood somewhere mixed up into aliquoting of the bevacizumab off-label is. We're going direct production for an on-label. And then, of course, as I was commenting on the Protocol T, the goal in here, the ophthalmologist was wanting to get to potentially aflibercept and go through whatever steps are required. I think this really does raise some of those questions. I think all of us acknowledge that first-line therapy is first-line because it is usually very effective. But those step therapies can sometimes cause the patient to have fluid persist for a longer period. And the visual outcomes we saw in Protocol T were better in patients. There was a slight favoring towards the on-label medication. And there's also a recognition that sometimes it's easy for a payer system to think that less expensive is always better because, and it's adequate, I should say. And so it's better to use that because it's adequate for the treatment. And while I would acknowledge that it's adequate, if you look at the big picture, I think we're actually all aligned. If we can get better disease control with fewer injections, moving to something like aflibercept or even aflibercept 8 milligram or using a faricimab or other molecules that last, as was pointed out here, 12 weeks or longer in between doses, the overall burden on the system, including the cost on the system, may be ultimately reduced. So I think that can be an alignment there as we start to, parse out some of these details.
Oh, and I absolutely agree with you. I trained many medical directors over my 20-some-odd year career in the payer world. And one of the first rules we taught them was, first of all, look at what's right medically and what's going to produce the best outcome, and then try to titrate that with your fiscal responsibilities. And it does create a delicate balance point. And I don't think as yet we as payers are often as good at looking at the long-term cost outcome as we should. Maybe part of that is because there's a high level of turnover in payer plans, but that's not necessarily true in Medicare Advantage plans, where we know there's pretty good data that show Medicare Advantage members tend to stay with the health plan with which they initially enroll. This case also brings up some interesting socio-demographic points. An older gentleman who may not be able to drive himself, although as you pointed out, vision's still pretty good in this patient. But maybe there are some issues there. I've seen data that show that even in the best of circumstances, there's about a 12-hour burden time for patients with an intravitreal injection because you have to travel to the office, you have to have your injection, you have to wait a certain period of time, you have to travel back, and that takes out a big chunk of the day. So what are your thoughts about some of these time burden issues and socio-demographic burdens that we may as payers not think about? And I'll be perfectly honest with you, it's often difficult to write a policy because it's hard to write a policy for the exception as opposed to the rule.
Well, I'm glad you raised those points. You're exactly correct, Dr. Owens. The burden, I think the study was something like 11.7 hours, like 12 hours, like you said, of the overall burden when you go in for an injection, because there's prep, get your meds together, get dressed, get the granddaughter comes pick you up, drive whatever distance it is, sometimes these rural areas. And I take care of a lot of our rural patients in Arizona. We have built outreach clinics that to us are way out in these rural areas, and yet sometimes coming off the reservation or still smaller towns out in the distance, the burden for the patient coming in to what they perceive as the big city, which to us is the rural outreach clinic, is not insignificant. And then even if they have decent vision in the other eye, frequently we are dilating, examining, imaging, taking pictures, shining lights in the other eyeball. And so the patient is not feeling safe driving home. So now granddaughter closes her business. They bring the grandchild or the great-grandchild, and they're all take this whole day together. And then for the rest of the day, their eyes are sensitive and uncomfortable, a little scratchy, a little irritated. The burden's significant. And I think that from a payer perspective, it's also important to recognize not just the burden on the patient, but what about the overall cost? Because every time we see the patient, we need to assess and evaluate. We image, we dilate, we'll examine, we'll take imaging. Periodically, we'll do angiography in addition to OCT. And sometimes in some payer systems, I think the Advantage plans are getting better at this, but sometimes they silo out cost of drug from cost of visit. exam, imaging, angiogram, OCT. And if you look at the cumulative effect of the cost, perhaps using an agent that allows you 12 weeks or longer in between treatments, that the overall cost may actually be less. And that's a good thing to think through. Not to mention some payers have supported transportation services or other things to be considered in the overall cost of the healthcare treatment.
Yeah, I think you bring up a good point about there's probably plenty of room for a well-designed long-term cost analysis study that takes into all those factors that you brought up. And I don't think that that's been well done yet. Perhaps a good project for an enterprising PhD who wants to study long-term economics of this disease state. And as you appropriately point out, one of the things that you can do in Medicare Advantage plans is provide things like transportation and other potential support services for those patients who are affected by geography or other social determinants of health. So I think we should conclude this case. It was a successful outcome. We see the patient's visual acuity improved to 20/40 after 6 monthly treatments. At 1 year, visual acuity was maintained at 20/40, and the ophthalmologist adjusted the dosing interval to every 8 weeks, precisely one of those things that you pointed out might be not only beneficial from a cost standpoint, but also minimizes injection and travel burden on the patients. So what are your final thoughts on this case and its conclusion as we come to the end of this session?
Well, what a great classic index case here to review, Dr. Owens. I'm really glad we got to go through this. I think that this is a good classic example to lock away in our minds of the benefit of treatment, the hope that is out there. You see the patient's vision's improved, the anatomy, the retina's improved. We're stabilizing. We're not just stopping devastating outcome, though that is indeed step one, but we're accomplishing goal 2, and that is improving vision and stopping blood and fluid. And we're accomplishing goal 3, a reduction in the overall burden on the patient and their support system, to where now this patient's only going to be coming in, maybe 6 times a year for maintenance therapy. Potentially with some of these longer acting agents, we may be able to get out to with an 8 milligram or with 8 milligram of aflibercept or with faricimab, maybe even out to 10 or 12 weeks. So we have a reduced burden on the patient and their family, reduced burden on the healthcare system, potentially some cost savings, I think, overall for the healthcare system and for the payer. I think this is a really good example of what we want to be considering as we go forward. Again, macular degeneration is the number one cause for the patients with your Advantage plan to lose vision and the devastating consequences thereof. And in this case, the patient's other eye, thankfully, is okay. But I see repeatedly where I'm desperately trying to save the one eye that lets them see their grandchild, the one eye that lets them watch movies, with their aging spouse, the one eye that lets them to balance their own checkbook, drive a car, go to church, get to the grocery store. And I think that when we visualize the significance of the impact this disease has on lifestyle, everything from depression to risk of falls and everything else that can come in between, we realize how important it is to save and preserve and restore as much vision as we can in macular degeneration. I'm honored to do my little part as a surgeon to do these injections and provide the medicines and make the best decision we can. And I'm really grateful for the work that this organization is doing to try and align on how with this Payer Talk endeavors we can be aligned in our goals. Thank you, Dr. Owens.
Well, and thank you, Dr. Graff. And I've certainly enjoyed today's conversation, especially being able to take a typical case as well as to personalize it to some of the issues that we as payers may not think about. And of course, your goals there to preserve vision for those who otherwise 2 decades ago would not have had the opportunities we have today. And so with that, Dr. Graff, a big thank you for your time, your expertise, and your knowledge. And I'd like to open the discussion to our audience for any questions they may have. So Dr. Graff, we talked about that case and the good outcome and some of the challenges in that elderly patient. But what about one that maybe doesn't go so well? And that's a patient that maybe comes in, gets that initial anti-VEGF injection, and then can't get back to the office. What are the consequences of that in terms of disease progression? And then what do you need to do as an ophthalmologist to maybe get things back in control?
Yeah, I'm glad you asked that question, Dr. Owens. It is challenging. If a patient misses an appointment, there's a trough effect. These injections are proteins. These are antibodies, and they'll break down. And so the protein will degrade and it will lose its efficacy and will have a trough effect. If it's grandpa's back pain, well, then his back pain kicks in until he gets his medication. If it's diabetes, the sugar levels are going up because they're not treating it, and there are consequences of that. If it's hypertension and they miss their appropriate dose, then there's a risk of stroke and hypertensive damage. Well, in my world, when the anti-VEGF wears off, then the disease is unfettered, and the risk of recurring blood or fluid, sometimes devastating rehemorrhaging, can occur. So that's why we want these longer lasting medications, and that's why we want compliance for their care, because of the consequences of the trough effect of undertreated disease.
Great. Well, thank you for that. We have one question that I may begin to address, and you certainly feel free to chime in. And it's not one that probably has a simple answer, in that what is the cost of this therapy for a patient with insurance? And I'll certainly start off with, there's a lot of it depends there. Number one, do they have commercial or Medicare insurance? Number two, if they have Medicare, do they have a supplemental plan? For instance, most people know that Medicare Part B in its basic form is an 80-20 plan, which means 20% of the cost of the medication. Now that I've said that, there's a big difference between the cost of, say, generic bevacizumab versus the branded agents versus the biosimilars. On the other hand, many people have supplemental coverage, and once they've met a deductible, there may be little or no out-of-pocket costs. So it varies all over the place. And maybe what I should put over to you, Dr. Graff, is what do you see as maybe some of the cost challenges for those patients rather than the absolute cost?
Excellent question, Dr. Owens, and I think that's from one of our participants, that it does vary is probably the best answer for it. But patients do have the responsibility of 20% of the drug costs. If it's a few $100s every 4 weeks for a generic bevacizumab, that's still many dozens of dollars. If it's a over $2,000 a shot drug that may last for 4 months, the patient is stuck with several $100s. Sometimes a secondary or supplement may help. Additionally, there is a large philanthropic organization funded mostly, but many will donate to that, especially the drug companies themselves donate. Good Days and others will help pick up those costs. So that keeps the cost low. If everything's running smoothly in a well-oiled machine, the cost out of pocket is several dozen dollars for the patients each time they come, their standard copay, and a modest copay for their medication. If things are not running smoothly, or Good Days or other supplements are not available, or there are issues with benefits investigations we're trying to do, it can be several $100s every time a patient comes for treatment.
Okay, thank you. We're getting close to the bottom of the hour, but there is one more question we can get to before we give everybody their final instructions. And it's an interesting piece of data that 61% of counties in the U.S. lack an ophthalmologist. And it might say that might not only be ophthalmologists, but other specialists. And 24% don't even have an ophthalmologist or an optometrist. How can payers address this issue is the question. I think probably payers can't do a lot to get people to go to rural areas. It's just the nature of the specialty, that, among other things, being close to major centers, especially academic or tertiary care centers, is almost a must for some specialists, including ophthalmology. What we can do, especially in Medicare Advantage, is we have the ability to create case management, transportation services, link people up with community services to help to get them there. So those are things that we can do as payers to do that. I don't think we'll ever be able to eliminate the maldistribution of highly specialized physicians, at least as we know it now. So I don't know if you have any comments there, Dr. Graff. That's my thoughts.
I really appreciate your thoughts on that about kind of case management, Dr. Owens. I think that increasingly we're having payers, insurance companies that are have taken on a greater role there. That's been helpful. Another one that has started to gain some traction, especially COVID kind of pushed us into this, is an A and a B. The A is to authorize and pay for analysis of non-mydriatic camera images, because those can be easily placed in rural areas, and that is already happening in rural areas around the U.S. now, where the company, where an insurance company or a payer will pay for the modest fee to analyze imaging when the patient just shows up to a lab center and they get their pictures taken. The second one is to authorize and pay for, and this COVID helped to cause, there's silver lining to every black cloud, that doctors can do telemedicine. and can get the images and then meet with the patient and determine those who need to come in for treatment. Probably the last two comments would lay in the laps of the doctors. And we are trying to do this at our institution where we build clinics at more rural locations and we travel out to those areas, number one. And then number two, we facilitate when patients need to get in or they cancel when there's snow or mud or flooding. We are quick to respond and get them in to the next available opening. That's on us.
Right. And it is a team effort. And I do like your comment about the camera imaging. I've seen some of those systems, and they do have very, very crisp and clear images of the retina that specialists like you and others can really make an assessment. And that may be one of the other solutions. So with that, we need to conclude the webcast. And again, thank you so much, Dr. Graff, for all your insight and discussion. Also want to thank Regeneron Pharmaceuticals for their support of the educational activity. And speaking of that, for those who wish to claim credit for this activity, you do need to complete the evaluation link for the activity. Once your evaluation is complete and submitted, you'll be able to select the type of credit you require. You do need to claim that credit to get your certificate, and for pharmacists, submit to CPE Monitor. And always those evaluations are important for us so we can continue to do better and better on these programs. And so that does conclude today's webcast. And I wish everybody a big thanks and enjoy the rest of your day.